Hi, this is Brian Kim. I want to share with you this case of a patient who was referred for a very dense cataract. The surgeon actually got started and had basically got stuck, used about 93 CDE to create a cruciate appearance to the lens, but then basically stopped and aborted the case. And I'm calling this Revenge of Cataract on Nigra Part 2 because my previous video shows how I was able to very carefully and slowly and methodically disassemble this terrible dense cataract. You can see this is how the patient looked in the clinic when I saw him. There was a small rhexis I had to widen. There was significant zonulopathy. I had to put capsule retractors. And then I had to employ all the techniques I know, terminal chop, cross chop, mechanical fracturing techniques to disassemble this lens. But I knew that this patient had a dead bag, basically. Also, there was a tiny posterior capsule rupture. So I already made up my mind that I'm going to abandon this bag. I'm not going to put a lens in this bag. This bag is unstable. And there's no sense in trying to salvage this bag because I already know it's not really in good condition. So I decided to do a Yamane technique on this patient. And I did this, mind you, I did this Yamane technique on the patient on the same day of the cataract surgery. So I filled the eye with dispersive viscoelastic. And then I go ahead and make my ink marks. Again, this is a 27 gauge cannula with ink on the tip. I ink the limbus on the right side, find 180 degrees apart on the left side and do the same thing. And I'm indenting the sclera with the fixed caliper 2.5 millimeters posterior to that limbal mark in radial fashion and then 2 millimeters adjacent. And then I'm going to ink those scleral indentations with the 27 gauge cannula. You always have to dry. If you don't dry, you're not going to get a nice discrete mark. Again, indenting 2.5 millimeters posterior to the limbus and then 2 millimeters adjacent with the fixed caliper from Epsilon. Again, I have no financial interests. And then I follow up the indentation by marking those spots with the 27 gauge cannula. Indenting the sclera 4 millimeters posterior to the limbus with the back of the trocar, and I'm tunneling tangentially, tunnel about 3 millimeters, and then I dive down vertically, take out the blade, and you can see the trocar cannula is sitting sideways, which hopefully will mean I'm able to get a self-sealing sclerotomy. The patient's nose is in the way, so I'm using the incision with forceps to turn the eye up towards me, and I make my contralateral limbal incision, which will help me to externalize the leading haptic. I make my main incision with a 2.4 millimeter blade, but then I realized that I normally make a 3 millimeter incision when I do the Yamane, so I had to go back and widen the incision with my paracentesis blade. And this is the cartridge for the Sensar lens. I pushed some cohesive viscoelastic into the barrel and on the platform, placed the Sensar AR40 lens into the platform, making sure the edges of the optic are seated down, and then bend the wings together. And as I do this, the optic bends backwards. The leading haptic goes straight into the barrel, and the trailing haptic goes out through the back. Slide the cartridge into the injector, making sure the trailing haptic is outside of the barrel. Advance the plunger, and I'm ready to go. This is my 25 gauge needle. I want to bend it fairly close to the tip with some BSS and a syringe, bending it so that the bevel is facing to the right. And this is a 30 gauge thin wall needle for the right side. I'm bending it in such a way that the bevel is going to face towards the main incision. And this is the left side 30 gauge thin wall, which I'm going to bend with the bevel facing towards the contralateral limbal incision. This is a 22 gauge thin walled AC maintainer. Slide the 25 gauge needle into the contralateral limbal incision, placing the injector through the main incision. Have the bevels face each other. The needle bevel is facing to the right and the injector bevel is facing to the left. My assistant is advancing the lens, and as she does this, I'm able to dock the haptic on the bevel and the needle. She keeps advancing, and then the haptic is internalized into the needle more and more. I pull the needle out and the haptic comes out. I take over and deliver the optic, in the proper orientation, and then deliver the trailing haptic outside the eye. Repositioning the optic so that it's underneath the AC maintainer. You want to make sure the leading haptic is pulled further outside of the eye. I'm pushing some more dispersive viscoelastic to coat the cornea and push the optic back. Holding the trocar, I'm stabbing the conjunctiva and sclera a little bit on an acute angle. Stab, and then I turn on infusion. And as I turn on infusion, I tunnel 2 millimeters, staying nice and flat, going through the sclera, and then I dive down. I can feel the resistance of the needle going through the sclera, 2 millimeters, and that means I'm confident I'll have a nice scleral shelf and excellent positioning and support of the lens with that shelf. I don't know if you caught that right there. I actually had to use my microforceps to make sure I punctured the needle through the capsular bag. So mind you, I did not remove the capsular bag yet. So I punctured, and I had punctured not just through the sclera, but also through the capsular bag. Now what's interesting is I did not lose any vitreous throughout these maneuvers, and I will deal with that capsular bag later. So I go ahead and slide the trailing haptic sideways so it goes in nice and gently into the eye with the smooth microforceps. And then I'm trying to dock the haptic on the bevel of the needle. You can see the leading haptic is outside the eye, the optic's pushed away, and this gives me great access and ability to position that needle to align with the haptic. Dock the haptic on the bevel of the needle, and all it takes is a couple of pushes, 1, 2, and we're in. Go ahead and disengage the needle from the syringe and then lay it down. Even though it took me a bit to get that haptic in the needle, I was very calm, I'm very controlled, and I was eventually able to get it. Pull the leading haptic into the eye with the microforceps. Grabbing the contralateral limbal incision with forceps, which will keep the eye in the neutral position, stabbing the conj and sclera at the first mark, and then I turn on infusion, firm up the eye, flatten out my needle, make sure I tunnel 2 millimeters through the sclera, and then I dive down. You want to make sure before you start advancing that needle through the sclera that the eye is nice and firm, because a firm eye is a more easily controlled eye, and it also ensures that you're going to place that needle properly. Again, you can see here I'm having to manipulate that needle and making sure I cleared the capsule, and I use the microforceps to help me do that. And then once I've cleared the needle of the capsular bag material, I go ahead and grasp the haptic, dock the haptic on the bevel of the needle. You can see because even though it's the second needle, it's not so hard because all of the action is away from me. From an ergonomic perspective, this is so much easier to deal with that second haptic. Again, the first haptic's already tethered to that needle on the right side, and this left side needle is so easy. 2 pushes and then we're ready to go. Pull both needles out, but not all the way. And then I start to pull the left side needle out all the way, but I make sure I have smooth forceps to grab it. I'm pulling the needle towards me because that's the direction it came. And I want to limit how much haptic comes outside the eye. Because if you allow too much haptic to come outside the eye, that means you're creating unnecessary stress on the optic haptic junction. And you don't want to do that. You don't want to cause any unnatural manipulation of the haptic. Cauterize the tip and then do the same thing on the other side, but I'm pulling the needle away from me because again that's the direction it came, and I'm limiting how much of that haptic comes out because I keep pushing it into the eye with the forceps. Dry off the surface of the eye because you can't cauterize when there's water. Get nice cute little bulbs there, and then I'm pushing the haptics flush to the sclera, reapproximating the conjunctiva. Perfectly centered lens, but not just perfectly centered, but also perfectly positioned from an anterior-posterior perspective with as little tilt as possible. As I'm doing the vitrectomy from the trocar, you will notice I'm not just doing a vitrectomy, I'm actually removing the bag. And now you can see that this bag was worth nothing because as I'm eating the bag, the capsule fornix material, you can see it's kind of got this kind of squiggly edges. That capsular bag was basically worthless. And with just a little bit of traction from the vitrector as I'm using vacuum, the whole bag just came out with very little effort. So I knew that I had to get rid of it. Pushing some intracameral Kenalog. And you can see again, there's no vitreous. Did the surgical PI using the vitrector, again on its own setting, discrete, small PI, but you don't want to stick the vitrector too far into the periphery, which might eat the ciliary body. Go ahead and close the main incision with the tendonolon suture. Using the vitrector with cortex mode, removing the viscoelastic that's in the anterior chamber. Pull the trocar needle out, massage the conjunctiva and sclera, turn on infusion. But look, I'm getting ballooning. So in this case, I did not get a good self-sealing sclerotomy, but that's okay. Even though I thought I executed it properly, I must not have. I'm using the Wexel sponge to be able to identify the sclerotomy, and I'm using that same tendonolon suture now. I go ahead and pass the suture through the sclerotomy, and then I push the suture needle through the conjunctiva, and then I'm going to push the needle through the other side of the conjunctiva, and then I'm going to close the sclerotomy. I use this tendonolon suture, one, because I already had it, and then two, I'm able to just go ahead and close it and just cut it out later. But it's very important to be able to get that sclerotomy closed. Go ahead and hydrate my incisions, and that's really the end of the case. So you can see this is a patient who had a really dense cataract. The surgeon used a CDE of 93. He couldn't get the lens out. There was a dense posterior plate. There was terrible zonulopathy in this case. And I had to deal with this challenging situation. Luckily, I was able to get the cataract all out without losing any lens pieces and without losing vitreous, but clearly the bag was unsalvageable. And so I go ahead and perform the Yamane technique while the bag was inside the eye. And why? Because the bag is acting like a shield. The anterior hyaloid face is intact. Why take the bag out first? It makes no sense. So I go ahead and execute the Yamane technique, externalizing the leading haptic, threading the right side needle through the sclera, cannulating the trailing haptic with my modified technique, doing the same thing on the other side. And remember, as I passed that needle, I had to push the needle and clear the capsular bag material before I threaded the haptic into the needles. And then once I executed the Yamane properly, go ahead later after that, I cleaned up the bag, removed the bag, and removed any vitreous, because at that point, it's okay to do the vitrectomy because I'm basically already done with the case. And again, you saw at the end, I had no vitreous exposure in the anterior chamber. And why is that? Because I've already cleaned up all my incisions. I closed up. All of the action was posterior. So there'd be no reason for that vitreous to come forward. But I went ahead and did the vitrectomy, closed my incisions, and this patient did very well. Again, revenge of Cataract Nigra Part 2. In the first Cataract Nigra case, I was the one that got beat up. But in this case, I was the one that was victorious, and this patient did very well. So I hope this was helpful to you, and I thank you for your attention.